Bob and I are meeting tomorrow afternoon, and Linda Powell, something set up Beatrice. Yeah, and had a nice meeting with Craig.
Good.
Yeah, no, it's like, well, the nice thing is it actually doesn't end at the end of this week.
Yeah.
So, yeah, that's
Where
pretty
you two
good.
met? Okay. Good.
Yes,
Great.
yes.
Great to see you. Okay.
Mm-hmm.
Very excited to hear it. How are you?
I'm good, thanks. How about you?
Mm-hmm.
Okay. Follow up on just some of this. So comparative field research that you did, because we looked at other medicines of medicine, and there was one theme among the different types of medical specialties studying sorts of fields has to do with though the medicines vary, the context is much better to make it part of their strategy to find ways to reduce infections. Great resume so far.
I'm overdue to come up and talk with you. Up the hill,
Up
right?
the hill, yeah.
Yeah, wonderful. Okay.
Are you doing a circuit after this?
Yes.
So go once you can. Hey, good stuff.
We'll take you over there. He comes over and coaches us there.
Oh, he does the same for us? He does. Did you see in our paper on oversights in the, for example, diagnosis there? Collection of anecdotes and opinions. Getting a lot of places.
Hello.
Sir.
Oh, hi.
David,
We've
nice
met
to-
before.
yes, we have.
Absolutely. Yeah.
Good to see you. Thank you for coming.
Thank you for showing up. Yeah.
Show up as often as I can. There's a whole typology around it.
I've seen it. Yeah. I talk a lot about
So you know this No, they're not that funny.
No. This is.
Yeah, this is all right.
Yeah, they're not.
Yeah.
There's a lot of people who are, retired practitioners,
Yeah.
but they're sort of more of a slight, more heavy evaluation on science and evidence.
Good. Okay. Well,
Thanks for checking. Okay.
we built that in.
Ready to go? Okay. Good morning, everybody. Thank you for coming. I'm Arnie Milstein, director of Stanford's Clinical Excellence Research Center, and I have the pleasure this morning of introducing our grand round speaker, David Sobel. I think I will dispense with some of the usual, references to David's academic accomplishments and really focus on my personal exposure to him over really the last 20 years. And it really began when I was asked to chair the Pay for Performance committee that governs how the HMOs in California distribute reward funds among medical groups across California, serving California's HMO population. And my job was to be arbiter among the groups and try to make sure that some collective vision of fairness was achieved. And about 2 or 3 years into it, quite a few of the leaders of the medical groups began proposing that Permanente be excluded from the calculations because their high scores on patient satisfaction with physician services and with some of the technical aspects of medicine, such as hypertension control, were so far superior to anything that they had achieved that they thought it would depress all opportunity that they would have for earning the rewards. This intrigued me, and I followed up with some of the people who were leading these efforts, and especially the hypertension control, because just FYI, I think the national numbers are around roughly 65 to 70% of hypertensives being controlled, and Permanente, in the last publication in a major journal, was pushing 90%. And if you run the calculations on what this does to a population mortality and morbidity, it's a tremendous dividend. And for any of you, who've tried to manage a difficult hypertensive patient, you know how difficult it might be to achieve anything approaching 90% control among your hypertensive population. And so I began to look into it a little bit further, and as I talked to network within Permanente Medical Group, they kept saying, talk to David Sobel. And they said, he is the person who we look to within Permanente when we want to mobilize scientific evidence in practical ways to begin not only to modify patient behavior, which is an enormous contributor to population health, but also physician behavior, particularly in the very difficult sphere of convincing physicians that doing anything to modify patient behavior is even feasible. David is the person who, before we made him a consulting professor here at Stanford, was responsible for making this happen within the Permanente Medical Group, both deeper patient engagement leading to better population-wide scores on measures of quality and patient experience, as well as persuading physicians to interact with patients differently. David, welcome, and we look forward to hearing about your journey and picking up some practical tips.
Thank you. Do you hear them cheering over there? I like modeling. So, for the last 35 years, in practicing medicine and doing patient education, health promotion, there are really three questions. There are three questions that I have pondered. And I'm going to give you some of my tentative answers to this, and I'm hoping during the discussion or after you can actually share some of your insights. And the first question is, when I look in the healthcare system, I see doctors working really hard. I see nurses, frontline staff, administrators, all working really hard. So I ask myself, where is the underutilized capacity within the healthcare system if we're going to make major improvements? Where is that? Now, I know we have to work on improving the efficiency and effectiveness of the work we do as professionals, but where's the underutilized capacity? And the second is, where's there mismatches between what patients bring into the healthcare system and the services that we offer? Because those mismatches waste a lot of resource, missed opportunities in terms of improving quality outcomes, and they frustrate patients and frustrate clinicians. So where are the mismatches? Finally, how do we find the sweet spot? How do we find those situations where we can intervene or change care so that we get a win-win-win situation? The patients say it's better, more satisfying care. We get better and more satisfying clinical outcomes. And at the same time, the organization benefits by providing more value and more efficient care. So the objectives for this particular presentation will focus on that, but I really want to work on assessing and aligning treatment recommendations with patients' intrinsic motivation to elicit patient-generated solutions and behavior change goals, and integrate positive, pleasurable activities to improve mood and health outcomes. And I want to try to make this practical. So my challenges in this presentation, given the time, is I could stand in front of you and only present graphs, slides, data, and spreadsheets. But if I know anything about behavior change, I know that while that may be necessary, it's not sufficient usually for changing either clinician behavior or patient behavior. So I'm going to weave into the presentation some stories, some practice tips, some skills that are also evidence-based, and I'm going to hope I get the balance right, and you'll have to let me know. So here's three observations about the healthcare field that I think are underappreciated. First of all, clinician well-being matters, and I'm going to discuss that. Second, self-care matters, and third, mind, mood, and behavior matters. So let's dive in. So all of you are familiar with the triple aim, and we all want to improve cost outcomes, health outcomes, as well as patient satisfaction. There's something gnawing in my gut that has always bothered me when I looked at it. And I woke up one morning and I had an aha. Wait a minute, what about clinician well-being? And so I said, it has to go from the triple aim to the quadruple aim. And I got very excited because I thought I had an original idea. So I quickly searched and found out that one of my colleagues, Tom Bodenheimer, had already written a paper on going to the from the triple to the quadruple aim. I think that clinician experience needs to be put into the equation. And part of the reason is if we're going to engage patients as partners in care, we have to be partners to begin with. And a burned out, frustrated clinician is very unlikely to communicate well or form a partnership with the patient. And it's no secret, physicians are stressed. One survey showed 87% moderately to severely stressed and burned out, and 40% severely. And 63% are less satisfied and feel more frustration in practice than 3 years ago. Now, I learned about this the hard way because I developed a program called the 5-Minute Educator, and the idea was to take this to our clinicians and teach them how to use the few minutes that they have to do more effective patient engagement and education. So I took it to our chiefs of patient education. We did an interactive workshop, had a great time, and I said, go forth, carry this back to the medical center. And they said, get out of my face. I said, what do you mean? They said, we are so stressed. Don't give us more stuff to do. So being in health education, we took that as a needs assessment. And we went back and said, if the physicians are feeling frustrated, what can we do? And so we made a whole list of all the things that might be levers to pull on physician satisfaction and frustration. Most of them we couldn't touch. You know, at the time, couldn't get the charts there on time. I couldn't hire more medical assistants. I couldn't raise salaries. I couldn't get them happier with their spouse or significant other. But the one thing we thought of is if you're in clinical medicine, unless you're a pathologist, if you don't enjoy and feel comfortable with the human interchange and communication with patients, at the end of a day, at the end of a year, at the end of a career, you're unlikely to have found that practice very satisfying. So we said, what can we do to improve satisfaction among clinicians by working on communication? So we surveyed the physician and found out what were some of the problems they were having, the frustrations, the difficulties in communicating with patients. And then a very smart internist joined our group, Terry Stein. And Terry did a reframing. She said, we have to get to what's in it for the clinician. And so she called it Thriving in a Busy Practice and put together a day-long workshop on communication skills. It had the same content, really, as the 5-Minute Educator, but the framing was different. We would say to the physicians, we're going to teach you some skills today, and maybe they improve adherence, maybe you get higher quality patient satisfaction, maybe you get better quality of information on which you can make decisions and so on. But the main focus is how you feel and helping you feel more comfortable. Well, it was based on something called the 4 Habits model. Well, the results were pretty astounding. From get out of my face, we'd had over 4,000 physicians voluntarily go through the training. And the physicians were rating the overall training on a Likert scale of 1 to 7, 6.2. Now, I just want to tell you, physicians never rate anything at 6.2 on a scale of 7. It's just not in our DNA, I think. Well, it turns out physician satisfaction went up. People felt less frustrated. And the evaluations came back and they said, finally, somebody cares about us. You know, all the focus on quality of care and better outcome and cost and so on. Finally, somebody cares about us. So I learned a lot about how important clinician well-being is, even in the framing of the interventions that we make. A nice side effect, I would say, maybe it's a main effect, is that patient satisfaction scores also went up. And the program has continued to evolve. Self-care matters. Here's an underappreciated but obvious thing. What do patients do when they have symptoms? When you do diary studies of patients, you find that 80% of patients will have some type of medical symptom or problem in any given 2-week period. And when you find out what they actually did for those symptoms, you find out that very few of them come to see us. In fact, only about 20% will seek professional medical care or advice for the symptoms they're having. 80% is practicing self-care. Now, I am not saying patients are always doing a great job about this. Sometimes they're doing some self-care that may miss opportunities for effective treatment or delay care. And sometimes they're doing care that actually makes the symptoms worse. But on balance, we haven't really focused on how do we help people do a better job of self-care. In fact, when we look at the healthcare system, we're looking at the tip of the iceberg. When we go to do care redesign, we usually are reorganizing the professional system, but not looking at the major resource in the healthcare system, which are the decisions people are making every single day. And so we undertook at Kaiser Permanente, and the bottom line is patients are the true primary care providers. And if you were really redesigning a healthcare system, you would start with the question, how do you educate, equip, and empower the true primary care provider? So we undertook a program in Kaiser Permanente of distributing the Kaiser Permanente HealthWise Handbook and training staff on how can you encourage and support and reinforce effective, safe self-care. The book contained over 140 medical problems and symptoms on when should you seek medical advice because it'll change the natural history or could be something serious, and how do you do effective self-care. And it turned out we were able to show that acute visits went down about 5%, all visits went down about 1%. We had a decrease in telephone calls to the advice center. 68% of the patients using the book said that it saved at least one physician visit. 76 reported that it saved at least one telephone call. And member satisfaction with the health plan went up. This is one of those situations. It's a win-win-win because we focused on educating and equipping the true primary care provider. Now, that was largely for acute illness. And so we turned to chronic disease. And I had the great fortune of meeting and starting to work with Kate Lorg and Hal Holman here at Stanford in the Center for Research in Patient Education. And we worked on the development and then evaluation and dissemination of the chronic disease self-management program. These are, you bring people with mixed chronic disease together, you train lay leaders in 5 days how to facilitate a very structured curriculum and program, but highly interactive, and you focus on increasing people's sense of confidence and control. So very quickly, what did we learn about outcomes from this? Well, we found out, first of all, it does improve health behaviors, self-efficacy, and various measures of health status and function. It also looks to be highly cost-effective, ranging anywhere from 2-to-1 to 10-to-1 reductions in return on investment from reductions in hospital days, ED visits, and physician visits, and is very scalable. If only 5% of the adult population with one or more chronic conditions would undergo this, we might be able to realize a $3.3 billion return. And the outcomes are long-lasting. Do you know many other drugs, medication, treatments that you apply for only 6 weeks, 2 years later, you're seeing continued benefits, and it can be replicated and disseminated. It's now in about 50 countries, and probably over 1 million patients worldwide have gone through the program. So what did we learn about the process? First of all, we learned that they said we were crazy at the beginning because we were putting people together with mixed chronic illness. But let me just ask you, when you see people with chronic illness, don't they tend to have more than one? And so do you send them over here for their heart disease, over here for their diabetes, over here for their hypertension? The analysis that we did is 80% of the skills people need to learn and practice with a chronic illness is common across all the chronic illnesses. So for efficiency, why don't we bring them all together, put them together, and let them learn those skills? But another important thing happened, and I'm not sure what's fully anticipated. When you bring people together with certain diseases, they focus on their disease. And we did not want people focusing on their disease. We wanted them to focus on the healthy living part and the things that they could do beyond their disease. And so therefore, that happens when you mix people. We also found out that lay people are as effective, and in some ways more effective, than health professionals in doing this kind of education, because the patients themselves are the experts in living day to day and coping with chronic illness, and they learn from each other. If you want people to know more about the facts of their disease, put a health professional in front of the group. We can choose one like House. They will know more. But if you want people to feel differently and more confident, and you want them to behave differently, it looks like they can do that much better from learning from each other. And what else we learned about the process is we asked people in the groups, why did you get better, and what did you most appreciate? And they said, I got to help somebody else. Now, I don't know how it is, but my patients don't walk into my office and say, Dr. Sobel, good afternoon, how can I help you today? That's not the way the relationship is structured. In these groups, people learn to appreciate their own strengths, their own ability, their own assets, and they focus on that by helping other people. And by social comparison, they look around the room, they say, things could be a lot worse, at least my kidneys work, or I can walk up 3 flights of stairs, and they begin not to focus on their disease, their disability, their limitations. They focus on their assets and their strengths. And that seems to be part of the magic sauce, if you will. The third area we'll focus on are mind, mood, and behavior matters. So when you look in primary care, and you look at the 10 most common symptoms that people bring in, let's say, to adult medicine, we're looking at chest pain, fatigue, dizziness, headache, back pain, edema, dyspnea, insomnia, abdominal pain, and numbness. To those in primary care adult medicine practice, that looks like an afternoon in the clinic. What happens when these patients are worked up? About 16% of the time we're able to identify a physical, organic explanation for the symptoms. About 10% of the time, we're bold enough to note that we think it's psychological. This is the surprising part. Unknown. 75% are unknown. Now, if you don't muck around too much and you give it a little bit of time, many of those symptoms get better on their own. But it turns out that the authors of this study and others suggest that a significant portion, not all, of the unknown is actually somatization. And I don't mean somatization, the psychiatric disorder. I just mean the expression of psychological and emotional distress through the amplification or production of somatic symptoms. Now, it turns out that this is very common. When you look at patients coming into primary care, about 10 to 20% will have a psychiatric disorder, but 80% or more will have high levels of psychosocial distress. Now, I cannot fix all that from my office. Jobs outsourced, economies change, wonderful little kids grow into teenagers. There's a whole bunch of factors we can't control. But if we are not identifying that as being one of the primary drivers of utilization and non-adherence, we are missing opportunities. We've instituted an extensive program in screening for intimate partner violence. And that's because if I'm standing there with a patient and I'm telling her all the things she needs to do to manage her diabetes, and what she's really thinking that's most salient is, I don't feel safe at home, we're unlikely to make very much progress. And we've developed a whole support system behind clinicians to allow them to open Pandora's box, knowing that it won't take their whole afternoon, because they have easy ways of referring people for appropriate services. And it turns out this psychological distress is really costly. They asked Willie Sutton, why do you rob banks? He said, because that's where the money is. So when you look at where a lot of resources are spent, it turns out comparing people with low or no stress, mild to moderate stress, or 3 times the medical expenditures for those with high stress. So I would submit to you that this is not something that we can ignore, and in fact something we can capitalize on. And furthermore, this psychological distress is disabling. In fact, when you look at mild depressive symptoms, these are symptoms that don't even qualify for a formal diagnosis of depression. They are often more debilitating than many of the chronic conditions we spend most of our time and resources managing. So what can we do about it? Can I send all these people to psychiatry? Is that going to work? No. First of all, they won't go. Second of all, the psychiatrists don't want to see them. And they could be better served with other resources. So we developed a line of psychoeducation programs. That's what we used to call them, but somehow that brought the Hitchcock image of, a shower curtain or something. So we renamed it behavioral health education. And these are skill-based educational programs. You don't have to have a diagnosis to get into them. It's about learning certain basic life skills. And it turns out they're non-stigmatizing, and patients are far more receptive to going into the program. So we have couples communication, anger management, overcoming depression. We have the chronic disease self-management program and a mind-body medicine program. Let me just show you some quick results from the mind-body medicine program. Very promising because depression levels went down by participation, anxiety, somatization went down. Look at medical utilization. We found this very curious. Psychiatry visits went down. Urgent care visits went down. Medicine visits went down. ED visits went down. And look at this. Drug and alcohol visits went up. And we thought that was kind of surprising at first. Then we looked at it. And what happens, many patients who go through the program realize that if they don't deal with the drug and alcohol problem, they're not going to make progress. And so therefore, they were more receptive and open to referral at that point to the services that are most likely to benefit them. So this is an example, I think, of better matching of what a real patient needs with the types of services that we could provide to improve their clinical outcomes. And finally, behavior matters. I've reflected on this sometime. If you look at almost any of our quality measures, a surprising thing comes up. At the end of the chain of those quality measures, patients have to change their behavior to get our quality scores. In other words, it's our patients who decide at the end of the day, despite how easy we make it, recommendations, hound them, it's they who decide to get the mammograms, get the pap smears, get their hemoglobin A1Cs checked, and so on. It's patient behavior. It's patients who decide whether they're going to follow and take the medications we prescribe. It's patients who decide whether they're going to seek care when it could help them or unnecessary care when it may not. It's patients, when it comes to lifestyle behavior, chronic disease management, it's their behavior at the end of the day that really determines it. So the bottom line for me is our clinical success, our quality scores, our satisfaction depends on patient behavior. And I actually think when we congratulate ourselves on our hypertension control or our quality measures, the patients deserve a little bit of credit for that, since they're the ones who are actually producing those results. So, behavior change matters. I'd like to address 4 questions with you briefly. Number 1, is behavior difficult to change? Are people really unmotivated? Does confidence and success matter? And finally, is everything that feels good bad for you? So let's start. Is behavior difficult to change? This is a source of enormous frustration among clinicians. We make the correct diagnosis, we give great advice, we prescribe treatments, and lo and behold, the patients don't do it. You know how patients say no to a doctor? Yes, doctor, whatever you say, and then they don't do it. In fact, give it to me straight, doc. How long do I have to ignore your advice? And when you think about it, this is the source of frustration to us. We're trying to do the best job we can. We just can't engage the patient. So I'm going to give you an arcane example, a strange example about changing behavior. This is a urinal in the men's room in the Schiphol airport in Amsterdam. And they were having trouble with something called spillage. And that is, frankly, guys just cannot aim. They can't see, and this is costly. They're having to send cleaning crews all the time to clean the urinals. And they tried all kinds of behavior change techniques. They put up signs, come on guys, please aim, and so on. Then they all said this is a difficult behavior to change. And then somebody who understood the male brain came up with a really elegant solution. For those who don't know, ladies maybe, guys cannot resist trying to hit that fly. And the result is an 80% decrease in spillage. Now, I like this example because we thought that the behavior was so difficult to change, but it was because we didn't understand the dynamics and the science between how to set up the environment and the environmental triggers to encourage the kind of behavior we were looking for. So I think behavior change is not rocket science, but it is science. And there's a whole wealth of behavioral science that we can draw from, and especially areas of marketing science, gamification, and the entertainment industry that are forever changing and shaping our behavior. We're about 20, 30 years behind in terms of harvesting this kind of knowledge and applying it. And in fact, honestly, a lot of our patient education, health education is so boring that we wonder, why do people not engage with it? And then we look in the entertainment industry, gamification, and see how engaged people can be often in mindless activities. So let me give you a couple of quick examples of how to harvest behavioral science and apply it in a busy clinical practice. Jamie Pennybaker down in Texas, a psychologist, found out that if you had people write about their deepest thoughts and feelings about traumatic experiences in their lives, you could improve a variety of health outcomes, including reducing physician visits. And then Smith did a study where he had patients with arthritis and with asthma write about the most stressful events in their lives, their deepest thoughts and feelings for 20 minutes for 3 consecutive days. The control group in that wrote about a daily diary of what happened during the day. What they found out after 4 months, lung function measurably improved by 12%, arthritis disease activity decreased by 28%, and there were clinical improvements much more profound. Let me ask you this. If this were a drug, would we prescribe it? Would we put it on the formulary? Let me give you another example. Blumenthal down at Duke took patients who had had an MI and randomized them to one of 3 interventions: usual care, an exercise group, or a cognitive behavioral stress group. Followed them for 5 years and determined that the stress management group had something like a 75% overall reduction in the number of cardiac events and the procedures that were required. If this were a drug, would we be prescribing it? Would we be putting it on the formulary and offering it to patients? And finally, we can harvest this behavioral science for better communication and outreach to our patients. We looked at some of the work of social influence by Robert Cialdini, and we said, how can we apply that to make our communication and reminders about preventive services more effective? So here's an example. Congratulations on getting your mammogram. That's the consistency principle. That is, people like to be consistent in their words and actions with how they see themselves and how they've behaved. So we immediately begin to align with the fact that the person is a type of person who gets preventive services. And then set completion is another thing. We hate to have a gap. We don't like that at all. When you have a stamp collection, you want to get that missing stamp or missing coin. When you break a dish, you want the full set. So when we say you have only 2 remaining gaps to complete your preventive care: mammogram done, congratulations. Pap smear done, congratulations. They don't like those empty boxes. And then finally, social proof. If you're walking down the campus and one person's looking up at the sky, you may walk right by. If you're walking down and 20 people are looking up, chances are you will look up. And that's by social norming, is we look to people around us who we think are similar to us and say, that behavior makes sense. And so therefore, the majority of my patients are up to date. Please join them. And finally, the authority principle is we tend to give more credence and are influenced more by people that we trust or think are legitimate authorities. Now, the cost of sending out a badly designed written letter is exactly the same as the cost of mailing a well-designed, behaviorally designed letter. And if you could improve by just a few percentage points the number of people who respond due to harvesting of behavioral principles and influence, if you could increase that, that's the opportunity to save lives. And so this has real impact in terms of outcomes and patients' lives. Are people really unmotivated? Or are they overwhelmed? When we look at patients, we often see their diseases, we see their preventive gaps, we see the lab tests that they need. You know, the patient's view is a little bit different. It's really a messy world they're dealing with, and they are motivated, but they're motivated to manage multiple life issues, some of which may include the medical issues which are priority to us. And there's something now called not only the burden of illness, but the burden of treatment. For a patient with type 2 diabetes, if they followed everything that the diabetes educator said to do, it would take 143 minutes extra a day. Let's get real. Are we setting people up for failure? So there's a movement now afoot in the UK and the US on minimally disruptive medicine. And it's trying to lessen and appreciate the footprint and the demands that we make on patients and set them up for unrealistic demands. Amy Tenderick, who's a patient advocate for diabetes, had a wonderful thing. We will use tools that answer our questions and solve our problems, and we'll avoid tools that help us do what you think we should do, and we won't use tools that add to the care and time and work of caring for ourselves. And I think that's really kind of sobering, because before we say people are unmotivated, we have to realize all the complexity that they're trying to manage. So are people really unmotivated? Well, sometimes they are. So the question is, before we say they're unmotivated and get cynical about it, we should say, do we really know what they're motivated about? And have we made it easier for them to do the things they're motivated about? And finally, have we identified and celebrated successes? So I don't remember much from calculus. In fact, I only remember one thing, and that's the area under the curve. So what I can tell you is, if you have the most difficult recalcitrant patient and you put all your time and energy into trying to change their behavior, you will burn out and you'll frustrate yourself. But the majority of our patients, they actually do want to change. They just don't know how. And so if you could shift that curve just a few percentage points, the area under the fat part of the curve gives you a much higher ROI and return on your investment. So even with the most difficult patient, if you can find some small thing that they actually care about, that they want to change, you're more likely to be successful. So in a sense, target the ready and willing, or target the ready and willing within any patient and help them do what they already want to do. So are people unmotivated? Well, I'm not sure we know what motivates them. A survey of 1,000 people found out diet and exercise are down pretty low. Job stress, caregiver stress, relationship stress, unhealthy sex life, money concerns, those are the things that really motivate people and are concerns. Does confidence matter? Kate Lorig published a study on the arthritis self-management program, which showed that behavior changed and health outcomes improved, and everybody got excited. In 1989, I saw this paper, and it had the conclusion, we were able to demonstrate only weak associations between the changes in behavior and the changes in health status. That's sacrilege in terms of health education theory. So what's going on? Well, let me tell you the story of Nasruddin the smuggler. He was very successful going back and forth across the border. And he got richer and richer, and they searched him from head to toe, and they could never find out what he was smuggling. He retired. He was sitting in a small cafe. A border guard came in and said, Nasruddin, what were you smuggling? And what did Nasruddin answer? It's right in front of you. Donkeys. He was smuggling donkeys. Now, I would submit to you that we've missed the donkey, that we have focused so much on preventive care, smoking, exercise, diet, medication adherence, and so on, which I think are really important, and I want my patients to do. But in the course of doing that, I think we've missed the donkey. So what's the donkey? Well, behavior does matter, because small steps can lead to a sustained health habit, and that does improve health outcomes. And that's where we want people exercising, changing their diet. But what we found out is that mind matters too, that small steps lead to success experiences, and when they're celebrated, That leads to improved health outcome by increasing self-efficacy, confidence, and optimism. And the reason that that's so important is what happens when we set people up for failure experience. What does that do to their sense of confidence and control? What Kate Lorg found, and later we found with the chronic disease, the main predictor of the improvement of health outcome was not the change in behavior. The main predictor was self-efficacy, or a sense of confidence and a sense of control. And so therefore, when we face all these different things that patients want to change and we want to change, can this confidence spread? Well, a study was done in New Zealand where they focused on just one thing, getting people to go to the gym. And we always hear about unintended harms and consequences. Well, look at the unintended benefits. They never mentioned smoking, alcohol, stress, temper, procrastination, and those outcomes improved. They only focused on getting people to go to the gym. And they were eating better, keeping their appointments. They could focus better. What I'm saying is there is a chance that when people focus on increasing a sense of confidence and control in one area, it may have some unintended benefits in other areas of their lives. So how do we produce success and failure? I have a formula for you. I have a graduate degree in prescribing failure. I know how to do it for myself. I know how to do it for my patients. My wife, talk to her. She'll tell you. My son, I know how to do it. Here's the formula, and it's not really too hard. Choose a behavior that's prescribed, that is, you tell somebody else what to do. Make it very general. You have to get more fit. You have to be healthier. You have to reduce your stress. Make it pretty difficult. I'm not talking about change for a week. I'm talking about a lifelong change. And if you can throw in that you have to give up something that you enjoy, that helps too. Now, what's the prescription for success? Choose a behavior that's personal, something that somebody cares about, wants to change. And it gets very specific. B.J. Fogg, the psychologist here, calls it crispy. It has to be really clear. I'm going to walk 3 times a week for 5 minutes with Harriet, and you set the goal for a week. We use something called the confidence test on a scale of 1 to 10. How confident are you that you'll be successful? If patients are less than 70%, revise the goal, make it easier, because they're likely to have a failure experience. I like rapid and immediate, pleasurable if possible. Some of the best change is when they focus on changing something in the environment, which changes the cues and the trigger, and celebrating success. Is everything that feels good bad for you? There's no improvement, Henry. Are you sure you've given up everything you enjoy? You know, sometimes I feel like I'm practicing medical terrorism. You know, I mean, like if anybody's having a good time, I'll find some reason it's bad for them. Well, that was the question we faced when I worked with a psychologist named Bob Ornstein, and we were thinking about the healthiest, hardiest people we knew, and actually thought that human beings evolved naturally to enjoy certain types of things because it increased either individual survival or the survival of the species. And so we asked a simple question: is there any evidence that feeling good is good for you? And what we did is we did a book called Healthy Pleasures, in which we identified the areas of sensuality, optimism, and altruism, and then asked the question, is there any evidence that if you do those things, they're going to be better? And so we looked at vacations and religion and kissing and relaxation and chocolate imagery, volunteering, shopping, sex, and so on. And actually we're able to marshal some evidence that doing those things, not only did you feel good at doing them, but you actually got to enjoy better physical as well as emotional health outcomes. So let me give you just a couple of quick examples. We evolved to enjoy nature. This is the first generation where our children are growing up without considerable exposure to nature. And when they did a study within a hospital, those patients admitted for surgery who looked out on a nature scene versus those who, by the luck of the draw, were on the other side of the hospital ward and looked out at a brown brick wall, the ones looking at nature had less distress, required less pain medication, and were discharged from the hospital as much as a day sooner. Again, it's a natural pleasure we evolved for. You know, most of the unhealthy pleasures turn out to be recent evolutionary experiences. You know, with a couple of million years, we might adapt to smoking. We might be able to drink 1.5 quarts of scotch a day. I don't have 1,000,000 years here, and neither do my patients, so the nice thing is we can channel them evolutionarily to the things that we evolved to enjoy, and they have. There's something now called nature deficit disorder as well. Oh, I like this one. There was a small Greek study that showed that men who took a siesta were 30 to 50% less likely to have a heart attack. Well, it was a small study, but then it was extended to 24,000 people, followed over 6 years. Occasional napping, 12% reduction. Frequent naps, 37% reduction. And since my specialty is preventive medicine, I take great pride in this, because as I look out in the audience right now, I see I'm practicing preventive medicine. But I'm going to wake you up after about 60 minutes, because after that, the curve in mortality seems to go up. So if you're going to snooze, make it 30 to 60 minutes. I want to finish with 3 quick stories. And they're drawn from clinical practice. I want to tell you about trout, I want to tell you about tires, and I want to tell you, tide and tires. So let's start with trout. There's a patient I was seeing. He looked a lot like Paul Giamatti. For HIPAA reasons, I'm not showing you his picture. Suffice it to say, he was overweight, hypertensive, hypercholesterolemic, and his hemoglobin A1C for his diabetes was 10.1, 10.2. It was not that I hadn't tried. I had tried motivational interviewing, brief negotiation, couples counseling, referred him to our diabetes education program. Nothing was working. And one day, I asked him a question. What do you really enjoy? And suddenly, he said, trout fishing. I love standing out in the stream. I don't care if I catch anything. I just love trout fishing. His whole mood changed. In that 30 seconds, 3 profound things happened. Number 1, I thought he was unmotivated. And then I had the aha. He was motivated. I was clueless about what he was motivated. What I needed to do was to align hemoglobin A1C in some meaningful way and link it to staying out in the trout stream where you can see the trout, where you can feel the rocks at the bottom of the stream, and where you haven't had a stroke and you can cast and still catch fish. Now, I've tried this question before. I tried it as, what's most meaningful in your life? Well, that's like a ton of bricks coming down. Or, what's your purpose in life? That doesn't work. So I went back to the screening for depression. And one of the questions is about anhedonia, or the inability to experience pleasure. I said, well, why don't we harvest that and bring it in? And so we bring it in by saying, what do you really enjoy? So it's a brief screening for depression, because if he looks back and says, there's nothing I enjoy, I cannot think of one thing, you have to think depression, finish the screening. And the third thing is this is a health promotion program for clinicians. Remember clinician well-being? Well, my day in the office, mucus, diarrhea, dizziness, headache, acting out teenagers, not a pretty picture. It turns out for a moment, I get to go trout fishing. For a moment, I get to fix and repair children's dolls, donate them to charity, and for a moment, I get to climb under a 1967 cherry red Camaro and restore it to pristine condition. The second one is a patient who couldn't remember to take her antihypertensive medications. I was about to flood her with suggestions of putting it on her toothbrush. Instead, I said, what do you think might work for you? She paused for a moment and she said, Tide. I'll put it on the Tide box. I'll put a reminder. I said, how confident are you it'll work? 80 to 90%. I said, that's great. Question, how long would it take you to come up with the Tide solution? It's not going to happen. The patients know the complexity and calculus of their life, the opportunities, the challenges, the barriers. And what the evidence suggests is patient-generated solutions are more likely to be successful. They understand the complexity of their life, and they own the solution. And the third one is such an ordinary, mundane thing that I love it because it shows you what a difference it makes. I took my car in for repair. Nothing was wrong with it, but he inspected the tires and came back and checked the mileage, and he said, are these the original tires? I said, yes. He said, well, I would have expected much more wear and tear on your tires if you had this mileage. You have done a great job of protecting your tires. Well, All right, look, there's a part of our brain, honestly, that just wants to feel good and party, that wants to be acknowledged for the efforts that we make. And so celebrating successes with patients, finding one small thing that they're doing in the complexity of their life, in the challenges of their life, and pulling those forward and celebrating them mutually is so important. I blew out my knee skiing. 20 years later, I saw an orthopedic surgeon. He looked at the x-ray. He said, David, I would have expected to see much more wear and tear on the cartilage of your knee. You've done a great job of protecting your knee. 20 years later, I remember that phrase. I remember it because it's visceral and it connected with me. And so patients have a litany of failures. Can we find one small thing to celebrate? So I urge you, when you're interacting with patients or colleagues, discover their passions. Ask them what they really enjoy. Instead of providing a litany of solutions, first invite patient-generated solutions. And finally, find something to celebrate, something you can genuinely appreciate in the struggle and changes. So let's go back to the three questions. Where's the excess capacity, an underutilized resource? I would argue patients aren't consumers of healthcare. They're the true primary care provider. Where are the mismatches that result in inefficiencies? I would say a lot lies in psychosocial distress, behavior, and the patient's need for information. And how do we create win-win-win situations? And I hope I've shared with you a couple of examples of how we can do it so it's better care, it's higher quality and more efficient care, it's more satisfying for patients, and it's more satisfying for us. Thank you.
Thanks, David. I think David will be able to stay later because I realize that there may be more questions in the next 5 or 6 minutes allow. But let's begin with your questions. Yes.
Is this talk available on YouTube?
Yes. If you search David Sobel on YouTube, I have a full Healthy Pleasures talk, which is about all the good things that feel good for you and are good for you. And then I have a separate hour-long talk on healthy behavior change. So yes, it's all on YouTube.
Yes.
It's a very inspiring talk, and thank you.
Thank you.
What, you mentioned one block that was missing in the beginning, and that was what's in it for me.
Yes.
What are you doing to have these same principles applied to physician behavior in their own personal lives? Medicine allows for no mistakes.
Okay. So I think the question was about what's in it for me, and especially the health promotion programs for clinicians. And we, within the medical group, now have a whole section of programs and activities that are designed for physician well-being. And interestingly enough, in many respects, it started with helping them be more efficient in practice and manage the electronic medical record, because what we found is that change and transition was the source of an enormous stress and frustration. So a lot of it focused on how do you get more efficient at being able to manage your day. And then, of course, it has the other types of health promotion activities for physicians. You know, we're human too. And the same skills and resources that our patients need to learn in mind-body medicine and so on, those same skills apply to us. And so we encourage our physicians to actually go through some of our educational programs as well.
Thank you.
Next.
I'd like to ask you a question about smoking cessation.
Yes.
You talked about small steps.
Yes.
Did you have success having people cut cigarettes down? My experience in clinical practice was they either quit completely or it didn't work.
Right. Actually, the evidence on that suggests, first of all, the good news is failure experiences in smoking cessation do not predict future success. In other words, people may have to try multiple times, multiple methods, learning from each what particularly works. And so tapering can, in some patients, can work. But there's another phenomenon called breakthrough change, which we understand very little about. And William Miller has called it quantum change. And you've seen patients. you struggled, and they've struggled to change. They get a heart attack. They have a diagnosis of a serious illness. And suddenly, without setting goals, without a lot of planning, they change radically things in their lives. So it can be crisis. Or I walked in to see a patient. He was sitting there smiling. He said, well, I'm eating better. I'm exercising. I said, what happened? He said, I fell in love. I want to put that on the formulary, okay? So it turns out that we don't understand a lot about breakthrough change. And in fact, we may interfere with breakthrough change by prescribing all kinds of goal-setting activities and so on for patients. So there's at least 4 pathways to change. One is breakthrough change, environmental change, pleasurable change, which I happen to enjoy, and finally, mastery experiences or setting small steps and goals.
You were next.
Truly inspiring and refreshing talk. Because we struggle more and more to have quality time with our patients. The follow-ups are very short and there are so many things to fulfill. What is your experience with applying this principle to groups of patients, and what would be the ideal size and the duration of these meetings?
Right. Well, we did a lot of innovative projects on what were called group medical appointments. And these are not classes because clinical care is actually delivered in the group setting. And some of them range anywhere from you have all your patients with diabetes, it's co-facilitated often with a social worker, a psychologist, and it's highly interactive, to the other extreme, which is called DIGMA, or drop-in medical group appointment, where 2 hours open, any patient can come, and you set some ground rules on privacy and so on, and then you begin to go around and say, why are you here today? How can I help you? Medication adjustments can be made, and then you say, anybody who has a specific concern they're not comfortable bringing up in the group, I'll save some time at the end of the group to manage. Those groups probably somewhere between 8 and 15 is probably a magic number in terms of being able to manage. Joe, have you run any group appointments in the oncology at all?
For 15 years.
Thank you. Okay. All right. You can talk to Joe Mason, one of my colleagues, who's had some direct experience with doing that. Thank you.
You were next. Yeah, over here.
No. I'm sorry. Weight loss programs. I'll tell you, when you talk about changing behavior, there's one of the hardest. A couple of rules of thumb. Number one, it's easier to prevent weight gain than it is to lose weight. And so a lot of our efforts are focusing now on pediatrics and bending the curve of weight gain. And physical activity and exercise looks like one of the most successful ways of doing it. It's hard to lose weight alone with physical activity and exercise, but preventing weight gain. And even at the same body weight, people who are physically active and exercising have mitigated many of the risks that are associated with overweight and obesity. So we have developed a whole program, first in Southern California, now it's also in Northern California, called Exercise as a Vital Sign. And we decided the area that we could make the biggest difference in terms of patients is assessing at every visit and establishing in the clinical record the minutes of physical activity and encouraging those wherever they are on the scale, except at the high end, wherever they are, every minute counts. And so we have lots of programs on weight loss and obesity. I think the community